building rapport. Yeah? Makes sense? I know a lot of you got that one. So let's move on to identifying the function and getting unstuck. Super important. So a skill that we use is called pros and cons. Okay? Pros and cons is evaluating the positives and the negatives of a patient's behaviors or decisions. Okay, sounds pretty simple, but a lot of times patients engage in behaviors and they just do it on autopilot and they don't really know why they do it. Or they do know why they do it, but they don't stop. Have you guys run across that? Or they just keep banging their head against the wall, but they keep doing it, right? Sometimes we do that. So for this example, for this slide, I'm gonna use a patient that maybe is in like a toxic relationship or an abusive relationship. So what are the costs and benefits of staying in this relationship, right? And then what we could add is, oh, well, I don't have it on here, but what we could add is what's called tipping the scales. I want to just add that. Tipping the scales is looking at the other side of it. So what are the costs and benefits of staying in the relationship? Let's tip the scales. What are the costs and benefits of leaving that relationship, right? So you get a chance to understand why are they staying, so they can see what they're getting out of it. What are the consequences of staying? What would be the consequences of leaving? What would be the benefits of leaving? And this really helps people to make an informed decision about their behavior, and I think it empowers them. And that's really what we want to do, is empower the patient to make their own decisions instead of us imparting that upon them. Okay, so now, next one, devil's advocate. This one is for a patient who's stuck. Right? They're stuck in a behavior that's ineffective, they know it, they keep doing it, right? So their behavior communicates that they're not going to stop. So with devil's advocate, what you want to do is you want to take an opposing stance to elicit the client's argument for change. So what does that mean? So I'm going to ask them questions to provoke them to think about the opposite. So when you have a patient who's in an abusive, toxic relationship, as a therapist, what's your priority, do you think? Safety, absolutely. So even though I might not overtly say it, what am I going to be trying to get the patient to do? Leave, right? I'm going to be trying to get them out of that toxic, abusive relationship. But what's going to happen if I ask them to do that, or if I specifically say that? What are they going to do? Yeah, they're going to, opposing forces, right? Anytime you put your opinion on somebody, patient or not, you're going to get an opposing force, right? So this is where we kind of want to be a little bit trickier, and we don't want to get into a power struggle with the patient. We want to avoid that as much as possible. So I would say something like, well, why would you leave him? You said you love him, and he's been good to you since the beginning, right? So now I'm aligning with this other part, which is basically the patient's behaviors. The behavior is they're staying. So good, why would you leave him? Why wouldn't you stay? Kind of that devil's advocate approach. So now it's going to get the patient thinking, but wait a minute, but I told you it wasn't good for me. I don't want to stay. And you want them getting that out loud. You want them talking that out loud, right? So that's devil's advocate. Now we want to take it one step further with the paradox. This is now, basically what the paradox is you are making the client uncomfortable in their current state to elicit an opposite response. So did you notice with devil's advocate what I did? Is I asked a question, why would you leave? Kind of opened it up for questioning to get them thinking. With the paradox though, I'm going to be very directive, and I'm going to align with their behavior, and I'm going to encourage them to do the very thing they're maybe already doing, but in their mind they know that they don't want to be doing. So for example, I would say something like, well, maybe you don't need to leave him. Maybe you need to move in with him and love him more and take the relationship more seriously, right? And then this is going to be very confusing for the patient, because ideally the therapist would be saying things like, you need to be safe and we need to make sure that you're okay. But instead, I might say, no, don't leave him, love him more, you're doing it wrong, right? So the idea with this is that, again, it's going to elicit them to argue for change or even make moves to get unstuck out of that place, because it's that whole opposing force. But here's what could potentially happen, and this is where we're going to get into the double paradox. What could potentially happen there is if I align that way with my patient and I encourage them to stay, they might then be like, well, that's pretty insensitive, because I've been telling you it's not a good relationship for me, and now you're telling me to love him more and to stay. Maybe that'll happen, maybe not. So what we could do is what's called the double paradox. So in the double paradox, I'm going to involve a third party. So for example, let's say I go and consult with my medical director and I say, Dr. Fidelio, I've got this lady, she's in an abusive, toxic relationship, and I think she should leave, but she's not leaving. And Dr. Fidelio says, well, Amber, you've got it all wrong. No, in fact, she should stay, and she should love him more. She's not doing it right. That's why he's abusive, right? She needs to just do better. So then I would tell her this. I would say, okay, I consulted with my medical director, and my medical director says I've got it all wrong. That actually, I was telling you the wrong thing, that what you should be doing is moving in with him and being a better girlfriend and loving him more. So now, what's happened, especially if we have a patient who could be prone to splitting, now Dr. Fidelio is the bad guy because I didn't suggest it, right? So now she'll be opposing him versus opposing me. And now I've aligned with her to say, I messed up, I'm sorry. You know, I wanna help you, but this is what he thinks. So now if she's opposing anybody, it's him and not me, and now she's working with me, and we have that alliance. So again, these are just things to try and see how they go. A word of advice, I guess. If you have a highly suicidal patient, you don't want to use devil's advocate of the paradox. Yeah. You wouldn't want to say, you know what, maybe you should kill yourself. Maybe you should. Why not? Okay, obviously we wouldn't want to do that. So just so you know, for acutely suicidal folks, these aren't going to be. But to get them unstuck from maladaptive behaviors, this would be something that you could do. And then distorted thinking, right? So people are going to come in feeling very hopeless, feeling very burdened, and then, like Dr. Reyes was saying, they're going to get trapped in thoughts, catastrophic thoughts, fortune-telling thoughts. We really want to help them to identify that, to notice that that place of despair or hopelessness that they're in large part might be due to their thinking and not actual reality. So something like, if you leave him, you said that you'll always be alone and no one will ever love you. Do you know this to be true? Could it be that you're catastrophizing because you're afraid, right? So being able to identify the function, to be able to identify the behavior, the thoughts that are keeping him or her trapped in that depression. Okay, so in summary, helping them to get unstuck.